Bismillahirrahmanirrahim. Assalamu alaikum. Today we will talk about diabetes in children. Do you know how many types of diabetes? There are three types of diabetes, type 1 and type 2, which all you know. The third one is monogenic diabetes, also called MODY, maturity onset diabetes of young. We will discuss it later. Previously, a decade or 2 decades before, the diabetes was very common in developed countries. Diabetes in children was common in developed countries, which was more as compared to the developing countries and Asian countries. But now it is vice versa, because in developed countries and Western countries they control the diabetes, and now it has been increased in the Asian countries. So, what is the reason why Asian countries are having more diabetes in children nowadays? Before it was not that much like in developed countries, because of lifestyle changes. The children which are giving lot of time to the screens, children they are eating a fast food, their lifestyle has been changed a lot, and there is no physical activity, and there are no such programs in developing countries for the family programs of the exercise and healthy food diet. Even though there are multiple in schools they are telling them the healthy food, what are the benefits and other things they are teaching them, but it is even it needs a lot to work on this to reduce the diabetes ratio in the children. So environmental factor, dietary factor, and physical activity, these all factors are including in reducing the ratio of the diabetes in children, and it needs a lot of work and also help with the doctors and dietitians. So today we will discuss about anatomy, physiology, anatomy of the pancreas, physiology of homeostasis of the glucose, types of diabetes as I mentioned, and how to recognize if any baby who has present to you, who presents to you, and how to recognize that this baby is having diabetes. And then investigation, diagnosis by the investigation, diagnosis by the clinical features, and diagnosis by the investigation. And we will discuss about the complications and little bit about management. So these are the islet cells of Langerhans, which is a part of pancreatic cells. It has three types of cells, which are alpha cells, beta cells, and delta cells. So each cells is secreting a different hormone. The alpha cells are secreting glucagon, and beta cells are secreting insulin, and delta cells are secreting somatostatin and also gastrin. So beta cells which are secreting insulin, it is placed the location at the center of the pancreatic cell islets of Langerhans cells. These cells, beta cells, are at the center which secreting insulin hormone from the pancreas, and alpha cells which secreting glucagon, which are at the peripheral, or we can say outermost part of the Langerhans cells, islets of Langerhans cells, and the delta cells which are interspersed all over the Langerhans cells, so intermixed cells of the delta cells. So how we maintain blood glucose level in our body? Whenever we eat some carbohydrate food, or we are eating some sugary food, sugary drink or food, anything, our insulin is secreted from beta cells of pancreatic of the beta cell, which is located center of the Langerhans of the islet cells. So this insulin secrete, and will insulin take the glucose inside the cell. This is the first mechanism. Glucose is carbohydrates are outside the cell, so insulin secretes from the pancreas, and it take the insulin and it take sugar inside the cell. And if, for example, my body needs 100 particles of glucose sugar, but I am taking, my input is 400 or 500, what will happen? The remaining glucose, where it will go? The remaining glucose will go to the store in the form of glycogen. Where it is going to store? It is storage in the liver, muscles, fat, and these are the sites of storage in excessive glucose in the form of glycogen. So whenever I am in the fasting state, so see the glucose, I eat the carbohydrate food, glucose, then insulin release, and the use of glucose in which is my daily requirement. After that, if it is excessive glucose, excessive carbohydrate, it is going to be stored in the liver, in the muscle, and in the form of fat. And whenever I am in the fasting state, my glucose is not going to be low. What is the reason? The reason this at that time this stored form of glucose is used, my body is using this stored form of glucose, and this need the hormone glucagon. So glucagon has also the importance. So like the babies, you will receive, you will face a question in the exam. The babies who is having recurrent hypoglycemia, if mother is feeding, the baby is maintaining blood glucose level. But if mother is not feeding for 2-3 hours, which is the normal, baby developing hypoglycemia, which is called recurrent hypoglycemia. So these babies having no glycogen storage. These babies have no storage form of glucose, which is in the form of glycogen, because of there are some. This happen because of some enzymes, glycogen synthase enzyme. So they might have the deficiency of this enzyme. So these babies needs continuous feeding, even overnight feeding, so that we will prevent the hypoglycemia in those babies. So these babies are called, these disorders are called glycogen storage disorders. So as you know now, what is glycogen? Glycogen is the stored form of the glucose in liver, muscles, fat, etc. So they don't have storage form. We call the glycogen storage disorders, which are 0, type 1, type 2, so many types of GSDs, glycogen storage disorders. The next is actions of insulin and glucagon. These both hormones are very important. Insulin is secreted from the pancreatic cells, beta cells of the pancreas, and which are located in the center of Langerhans cells, and glucagon it is secreted from alpha cells of the Langerhans cells, islets of Langerhans cells. So what are the function of insulin and what is the function of glucagon? First, we will discuss the functions of glucagon. So glucagon increase the blood glucose concentration. How? Whenever we are in the fasting state and we don't eat the sugary food or carbohydrate, our body needs the glucose because it is the source of energy. Our body needs an energy. So at that time, this hormone will release. When we are in the fasting state, the glucagon will be released that the body needs some energy. So please be active. So glucagon comes and it will give our bodies energy from the stored form of glucose, which is in the form of glycogen. So breakdown of the glycogen, and that's why it is happening increased blood glucose concentration in our body. If there is no glucagon or there is no glycogen in our body, definitely we will not have a during fasting state we will not maintain the blood glucose level. Glucagon also increases blood fatty acid and keto acid concentration. It causes the increased lipolysis. This is the one of the reason in patient developing ketonuria or ketonemia, increased ketone level. Examiner may ask you what is the mechanism of ketone formation. It is because of increased lipolysis due to increased glucagon level in the body. So this lipids breakdown which forms the ketone and increased ketone concentration. And also glucagon increases urea production in our body. So the other thing, ketone formation, maybe you will face a question that ketone in our body, how it forms. Actually this is because of increased lipolysis, and beta hydroxybutyrate acid, and finally acetoacetate, which is produce the smell of, we are saying this is the cause more breathing and smell in the body, smell in the breathing system, that is fruit smell. So actions of insulin, what are the actions of insulin? Insulin decreases blood glucose concentration. Now you know how it decreases, because glucose is insulin is taking glucose inside the cell. That's why the blood glucose concentration will be low. Insulin decreases blood fatty acid and keto acid concentration. If there is lack of insulin, they will having blood fatty acid, and they develop a ketone formation in their body. So that's why this is the, because of in type 1 diabetes. Type 2 diabetes usually very it's very rare, or you can say they are not presenting with the diabetic ketoacidosis in children. Usually type 1 diabetes, which they present with the DKA, diabetic ketoacidosis, because they don't have insulin, and in type 2 they have some insulin, which is preventing them of developing DKA. So insulin decreases blood amino acid concentration. Insulin decreases blood potassium concentration. So this is also how it decreases the potassium concentration, because potassium is extracellular. Potassium is the extracellular, and it's not the intracellular. Whenever we are measuring potassium, it shows our extracellular potassium level in our body. Hypokalemia means extracellular potassium is low. Hyperkalemia, it means extracellular potassium is high. So the one of the function of insulin, it takes the potassium inside the cell. It takes the potassium inside the cell. This is the one of the function of the potassium. So if there is no insulin at all, what do you think? What will happen if there is no insulin? So there is no carrier. If potassium remains outside, when remains outside, potassium level will be increased. But if there is more insulin, then it would be hypokalemia, because potassium level, potassium from extracellular, it will take by the insulin to the intracellular, and extracellular potassium will be low, and what is causing hypokalemia. Some terminology you should aware of before going to appear in the exam, and if you know about this terminology, it will help you. Gluconeogenesis means synthesis of glucose from non-glucose precursors. So what are the non-glucose precursors? Which are amino acids, glycerol, and liver, and which are in the liver, kidney, and intestine. Glycolysis, which is oxidation of glucose to pyruvate with generation of ATP, which is the energy. Glycogenolysis, conversion of excess glucose to glycogen. As I told you, the glycogen is a storage form. So when you are eating excessive carbohydrate, sugary food, so this glucose is converted into the glycogen. They use this term glycogenesis. So this is helping with some enzyme, which is glycogen synthase and branching enzyme. If there is deficiency of this enzyme, the storage form will not be there in those babies. Glycogenolysis, degradation of glycogen to glucose. So glycogenolysis, when we are in the fasting state, our body is having glycogenolysis, because stored form is the glycogen. So it is breakdown, and then our body is taking glucose from glycogen. So types of diabetes. Type 1 diabetes, which is 95% diabetes in children, so it's huge, and they are asking usually question from the type 1 diabetes, but you should be able to differentiate either it is type 1, type 2, or monogenic diabetes. Type 2 diabetes, and then monogenic diabetes, maturity onset diabetes of young. Type 1 diabetes, the most common type of childhood form of diabetes. It is T cell mediated autoimmune damage, because what is the meaning of autoimmune? Why we are saying the autoimmune? Autoimmune means our own immune system is destroying our own cells. That's why it is called autoimmune. So there are some other conditions which are also autoimmune, like celiac disease, hyperthyroidism, hypothyroidism, diabetes type 1, which is T cell mediated. These are called the autoimmune disorders. So, what are causing damage to the beta cells, and how do you know that damage happened with the beta cell? You will see some antibodies, which are glutamate decarboxylase antibodies, which are GAD antibodies. If you think any babies who is having, you are suspecting diabetes, you do the GAD antibodies. If there are GAD antibodies are raised, you can say it is a T cell mediated autoimmune type 1 diabetes mellitus. And there is some HLA association, histocompatibility association, which is DQA, DQ8, and DRB. Usually in exam, sometimes they are asking about HLA association, but they are asking HLA association in the celiac disease, which is very common question in the exam. You should aware of the HLA association of the celiac disease, but type 1, which is DQA, DQ8, and DRB. Symptoms occur when 90% of beta cells have been destroyed. So 90% of beta cell are destroyed, then the babies or children will come to you that they have the symptoms of a diabetes. Before that, they are not developing the symptoms. We will discuss what are the symptoms. And in treatment is insulin therapy, and you should remember the names and the action of the insulin. That's enough for the exam, or you can say the short duration, long duration, intermediate. Just you should know the names of the insulin. Type 2 diabetes, which is unusual in children, and in which there is no ketoacidosis. What is the mechanism? Which is obesity induced insulin resistance. They have the insulin resistance because of their obesity, less activity, and Asian ethnicity, also ethnic groups. They have also some common type 2 diabetes, which is secondary to relative degree of insulin insufficiency. They have the insulin secretion from the pancreas. They have some beta cells, but which are not enough to maintain their blood glucose level. But they have the beta cells which secreting insulin, leading to excessive hepatic release of glucose. Supportive management, initially they need a supportive management, which are lifestyle changes, dietary changes, and exercises. If it is not responding, then we are giving them oral hypoglycemic drugs. The other is monogenic diabetes. I remember the one question they asked, which is the monogenic disorders from above, and they give some other genetic disorders. So it was a MODY, which is maturity onset of diabetes of young, in which there is a mutation of gene which is called HNF gene. And the common is, there are multiple types. The common is HNF1A gene, and they have the strong family of the MODY, and they need low insulin requirements. You are suspecting any babies who presents to you, and you are suspecting it is a diabetes, and you started with the treatment of insulin, but on the follow-up you see these maintaining glucose, recurrent hypoglycemia on this dose, so you reduce the insulin dose. Even though very minimal dose they are maintaining, you can suspect that this could be the MODY. But those children are non-obese children, not the obese children. And how to screen about the maturity onset of diabetes of young? We will do the urine C-peptide creatinine ratio. What is C-peptide? We will discuss later on. Confirmed by genetic testing. First you did the screening, you find there is abnormality in urine C-peptide creatinine ratio, then confirmed by the genetic testing, and the treatment is sulfonylurea. Another diabetes, sometimes in exam you will find neonatal diabetes. This is the neonatal diabetes, which is not very old. They recognize neonatal diabetes. They have also problem in some mutation of the genes. So in those babies they need sulfonylureas. So this is also, maybe you will face the question that the neonate who is having diagnosed with the diabetes, some genetic problem, and what treatment you will give, either insulin or oral hypoglycemic drug, sulfonylureas. Or so if neonatal diabetes, and they are telling you because of HNF1A gene or some other, they have some KR1 gene involvement. So this is those babies also need the sulfonylureas. What are the differences between type 1 and type 2? This is important because if you are diagnosing the type 1 and type 2, then the treatment is different in between both diabetes. So type 1 diabetes, which is most common, 95% in children, and which is autoimmune. Now you know what is autoimmune, which is T cell mediated, and they have HLA typing, which is DQA, DQ8, and DRB. They require insulin and can present with DKA. So the type 1 diabetes, they can present in the form of DKA as compared to type 2, which is less common and strong family history. And they have obesity induced, and treatment initially is lifestyle changes. If not responding, then oral hypoglycemic control medication for the patient who are having type 2 diabetes mellitus. So how to differentiate, for example, if it is very clear, usually from the clinical features and examination and by the routine investigation in any patient who is having hyperglycemia, we are knowing this is a type 1 or type 2. But if there is a problem that we need to know how to differentiate, either it is type 1 or type 2, there are certain other investigation we are doing to confirm the diagnosis, either it is the type 1 or type 2. So any patient who is having a diabetes, how you can label that this patient is having a diabetes? Because whenever any baby whose elevated blood glucose level more than 11 millimole per liter, or the symptoms plus fasting glucose more than 7 millimole. This is the actually WHO criteria which are followed by the UK as well. Any babies who is having elevated blood glucose more than 11 millimole per liter, or symptoms, we will discuss symptoms and fasting blood glucose 7 millimole per liter. Now remember one thing, any babies who is having hyperglycemia, please do not tell them to go and come in fasting state, because this is like you can say it is a contraindicated. So we don't send any babies who is having hyperglycemia and we will tell them to come back day after tomorrow or tomorrow in the fasting state. No, because they have very low glucose storage and they may go into the very severe hypoglycemia. We are not telling them to come in the fasting state. But if already they are in the fasting state, this is just definition. Symptoms plus fasting blood glucose more than 7 millimole per liter. Symptoms and signs, which is change in school performance, because children usually they don't complain of their symptoms, and the triage of symptoms which are common in type 1 and type 2 as well, which is polyuria, polydipsia, and wet loss. So polydipsia means thirst, excessive water drinking, and wet loss, and they might have oral thrush, some lesions in the mucosa of the oral cavity, and they have polyuria, excessive urination. These are the symptoms which are common in all. And nocturia, they have bedwetting. Usually they are controlled their bedwetting, but again they start to wet their bed at night, and excessive tiredness, and acanthosis nigricans, which are some blackish lesions, and the axilla in the patient who is having insulin resistance or type 2 diabetes. This is not the sign of type 1 diabetes. So how to investigate? Now you have diagnosed that this baby is having diabetes. Now how to investigate whether it is type 1 or type 2? You should know because the treatment is different. First of all, you will do height and weight as in every chronic condition in children. Then in blood, what we will see, we will do the glucose, we will do the electrolytes, we will do the pH, we will do the ketones, hemoglobin A1C, and full blood count, cholesterol and triglycerides, and TSH, T and FT4, immunoglobulin A, and antibody screen for thyroid, celiac, GAD, and islet cell antibodies. So now you know the GAD antibodies. If there are GAD antibodies and hyperglycemia, we are saying type 1 autoimmune T cell mediated diabetes type 1. So if they have the type 1 diabetes and you did get antibodies, so you will look for the other autoimmune diseases. As I mentioned, the hypothyroidism or hyperthyroidism, for which you will do the TSH and FT4, and celiac, for you do the screen for the celiac disease, tissue transglutaminase antibodies. So these other, and also IgA deficiency, which is happening in celiac disease, so immunoglobulin A you will do. So these are the other things which you should screen for, because they might have any other autoimmune disorder. Any babies who is having type 1 diabetes, they would have a weight loss, polyuria, polydipsia, and they might have a family history of thyroid disease, celiac disease, or diabetes type 1. And any babies who is obese and they have hyperglycemia, they might have type 2 diabetes in their family, and they don't have the weight loss, but other symptoms remaining the same. These are the main thing which you can differentiate from the clinical, from the history and examination. So now you know that this baby is suffering from diabetes type 1. So what other you diagnosed, you started treatment, but what other screening test you will do? You will do screening for the celiac disease, for the thyroid disease, and microvascular complication of diabetes of which are retinopathy, microalbuminuria, and also you will check the blood pressure. But examiner know that you know all these to check in the patient who is having type 1 diabetes. But at what time you will check? You will not check all these things at the presentation or at second presentation. At what time you will check? This is the and either you will repeat this or not. So for celiac disease, at the diagnosis, if you diagnose type 1 diabetes T cell mediated, you will do the celiac disease screening at the diagnosis. If there are no screening favors that this is a celiac disease, then you will not do. This is only once. Then thyroid diseases, as it is autoimmune, we will do at diagnosis and annually. Every year we will check for the thyroid disorders in the babies who is developing T cell mediated autoimmune diabetes type 1 at diagnosis and annually. Then retinopathy we will do annually from the age of 12 years. This retinopathy, macroalbuminuria, and blood pressure, these all we will check from the age of 12 years, and then annually every year from the age of 12 years. Whenever you see the question, you should check the age of the patient, not at which age he diagnosed. If he diagnosed at the age of 11 years, then we will do from 12 years onwards. Annually we'll check the retinopathy, macroalbuminuria, and blood pressure. So these are the things you should know of for the diabetes mellitus. And in diabetes, usually examiner is giving you the question that the baby who is usually you will find a question, a mother who is depressed mother and divorced, living separately, and she is her baby is suffering from the diabetes type 1 on insulin, and the recurrent history to the A&E with sudden onset hypoglycemia, and you are suspecting that this could be due to child abuse. Maybe mother is giving an excessive insulin because she's depressed and single mother. So these are the things. So how do you know this hypoglycemia is happening because of excessive insulin in the body? So they do the C-peptide level. You know, C-peptide, it is secreting the insulin secreting from our pancreas, which have that insulin has the C-peptide, but exogenous insulin, they don't have C-peptide. So whenever we find there is no C-peptide in baby's blood and insulin level is high, so we can say this is because of child abuse, exogenous insulin by the mother, and we can think about this is the child abuse, and they have the excessive insulin which is exogenous because they don't have C-peptide. This is the one reason. The other thing also, C-peptide sometimes they use to differentiate from type 1 or either those babies is having insulin. If they have insulin is high, they will see the C-peptide. Either they have this C-peptide. If there is C-peptide is high, it means that pancreas is still secreting the insulin. So these are the two reasons. And so today we discussed about type 1, type 2 and type monogenic diabetes, majority onset of diabetes of the young body, and how to differentiate clinically, how to differentiate by the investigations, and after you differentiate, how to recognize that this is that type 1 by the clinical history and examination, by the investigations, and how would you treat, and what other investigation you will do if it is type 1 which is autoimmune mediated, and you will do at which time your investigation you will do. So these are the things you should aware of before you are going to appear in the exam. Thank you very much. Assalamu alaikum.